McGerrison here. Welcome to TopMedTalk. And it's time for one of the top 10 most downloaded podcasts in the history of TopMedTalk so far. And this one is the Brain Health Initiative. Have a listen.
TopMedTalk. Welcome to the Roundtable on TopMedTalk. We're at the 6th Annual Conference for Enhanced Recovery and Perioperative Medicine, hosted by the American Society for Enhanced Recovery and EBPOM, Evidence-Based Perioperative Medicine Initiative. You can find more information about the meeting at acerhq.org and ebpom.org. My name is Desiree Chappell, host of the Roundtable, and we are joined today by Dr. Peden. She's a professor of anesthesiology at the University of Southern California and vice chair of the Perioperative Brain Health Initiative. And then we also have Dr. Fleisher. He's the chair of anesthesiology at the University of Pennsylvania, and he is also the chair of the Perioperative Brain Health Initiative as well. Thank you guys so much for joining us and taking the time. I know it's been a great conference, but a very demanding conference as well. I was so excited to have both of you here talking about the Brain Health Initiative and how that kind of impacts patients and how we as providers can learn from this. And so we've been talking about enhanced recovery and returning our patients to baseline and improving the outcomes for our patients. So I first would love to get a little bit about your background. What is the Brain Health Initiative, and how is that going to help us improve the way we take care of our patients?
So,
Dr. Fleischer.
Yes, so this started about 3-4 years ago with a discussion between Daniel Cole and myself around ensuring that we continue to do patient safety initiatives in the anesthesiology field that certainly were lauded for focusing on safety, but really if we look over the last 20 years since that attempt to make sure patients do not die during surgery from things that we do, we haven't focused specific in that area. And given Dan Cole, the former president of the ASA's interest, and as well as a space that we really have an opportunity to enhance recovery, it's around cognitive dysfunction, particularly after surgery, cognitive recovery in the elderly and those with mild cognitive to severe cognitive impairment. So the initiative began as a multi-stakeholder approach to define best evidence, implementation strategies, and sort of very patient-facing, because we wanted this to be patient-centered. In fact, our primary partner in this, besides the American College of Surgeons, and I'll talk about others in the future, is AARP, because we wanted to have that patient voice there, and they certainly have a huge impact in trying to make sure the elderly and their caregivers really are aware that patients do develop delirium, both in the hospital but also at home, and they do develop cognitive dysfunction. There's a lot of questions of, is it long-term? We're not sure. Is it related to anesthesia? We think it's related both to surgery and anesthesia and probably the inflammatory response. But we certainly believe it can last for up to 3 months. And again, it may go back to sort of the baseline trajectory of the patient, or we need to do more research on, does short-term implications affect long-term implications? So that's really the initiative, and we've spent about the last 18 months focusing on building out a website, and we'll have a second symposium or roundtable with a lot of other stakeholders, including federal partners and other specialty societies at AARP in June. But the hope is to define, again, the educational material for patients, working with ACS, who has already done a lot of work around safe surgery in the geriatric population with delirium. Nobody's really focused on cognitive recovery, and a provider-focused initiative, and then there'll be a research initiative. So it may be great to hear Carol, who's been focused on that quality improvement expertise, of how she's thinking we should implement certainly the provider focus, and perhaps the two of us can talk about the patient focus.
Yeah. Dr. Peden, I was specifically, when we talk about cognitive function, cognitive delirium, one of the things in our institution, it's a conversation we're having, but we're having a very difficult time defining what that means, determining what's really happening with the patient preoperatively. Do they even believe they have issues? And then who's at risk stratifying patients. So can you speak to that just a little bit about how do we get a hold on what it all means and how to determine what our patient?
Yeah, sure. I think there's a lot of science coming out at the moment and new definitions about perioperative cognitive dysfunction.
Yeah.
And I think that's not our area of main interest. I think what we're trying to address is the issues that matter to the patients. This story of Granny was never quite the same again, or I'm worried about, that I might be confused after surgery. So we're very interested in the practical aspects of what we say to patients, how we educate our colleagues to have those conversations in a way that informs the patient and family but doesn't scare them.
Right.
And as I say, the practical steps that people can do. So from the patient and family point of view, it's perhaps being aware that changes can happen. They're highly unlikely to be permanent. But if there is an element of confusion or delirium postoperatively, to ask for help, to understand it, that it may resolve. Preoperatively, to take simple steps like trying to bring a member of family with you and be there around the time of surgery, to make sure you've got glasses, hearing aids with you so you can be oriented. So very, very simple things. And from the provider point of view, what we're trying to do is bridge the gap between the science, and there's lots of exciting science going on, but to those practical steps.
Yep.
And what you find often is that they may not be happening as much as you think they should be. And providers are confused about exactly what they should do, where they should go for information. So the Perioperative Brain Health Initiative is about creating a site and a space to host those resources, whether they're the scientific papers or the key tips. And then also not just telling people what they should do, but giving them some resource to actually improve and implement change, because that's another thing again.
Yeah, you have to have, it's not enough just to say, I have a toolbox, but you have to have the tools in there to be
So we're trying to give them both the tools and the toolbox.
Yeah, that's fantastic. I actually sat down with the AARP president, Eric Schneiderwind, at the Value-Based Care Conference last month. And it was so great to hear him speak and talk to him. And, it really did hit home when he said, we're not asking what is the matter with the patients when we take them, or we're doing that, but what we need to do is ask them exactly what you said, Dr. Peden. What's the matter, and how can we make it better for you? What do you want your outcome to be whenever you come out? And I think that we all have, as providers that see patients postoperatively, and we all have that experience when we go in and something's not right, but only the patient's there. They don't have any family, don't have any reference. And I think those are some of the things that start to stress us out a little bit as a provider of, how do we tell when the patient is actually experiencing delirium and things such as that. So is that something part of your initiative that you're doing as well? Like recognition?
Right. I think we've heard lots of discussion about blood pressure, and we haven't heard a lot of discussion about brain function. And so we want to bring perioperative brain function into the conversation as much as we're discussing cardiac issues.
Yeah.
And really have that at the forefront of what people are thinking about.
Absolutely. Dr. Fleisher, what are you seeing as far as the literature that's coming out and the rate of cognitive dysfunction or delirium postoperatively? Does it really how much is this really happening?
It's so variable. If you talk to Henrik Kellett under ERAS, there is none. That may be a very Danish experience. I think if we looked at our hospitals carefully, it can be 30, 40, 50% depending on the population. And they say it's about 40% preventable. We don't know what works, but the incidence of papers coming out is tremendous. We're very excited that Sharon Inouye, who's probably in the delirium space, one of the foremost authorities, is part of our initiative. She's a gerontologist. She does a lot of research showing the effects of delirium on cognitive function for the next 2 to 3 to 4 months, even longer. So we just spoke with Franco Carli, who just was here, and I said, is there anything that's been shown to improve cognitive function after surgery as far as exercise, prehab? And the answer is no. So we need to do a lot more research, but people are starting to study whether or not different anesthetics techniques, certainly a lot around making sure we don't use the wrong drugs. And it's interesting. I went back to my own institution, and first of all, I found that diphenhydramine was actually on the postoperative orders. It just took a click. First thing I did was eliminate that, and I'm trying to work with nursing staff and Epic team to actually send up alerts. And I'd be curious from Carol's perspective, as we alert individuals to, and I mean providers, to what's bad. how do you think we can actually do a better job of at least not giving them things that make them worse?
Dr. Peden.
Well, I think one of the things is telling stories, and as you've done it, you getting the stories from the patient, bringing the patients in and making it real to the providers that this is what it means, and also providing them with the information, avoiding benzodiazepines. I tell a story which profoundly impacted me of visiting Deb Culley's lab, who's one of the world's experts on this subject, and her telling me about the effect that benzodiazepines had on elderly rats, that they couldn't get round the maze for days. And I was so surprised, that there was this incredibly profound effect that I never used benzodiazepines again in a patient over 70, but it should probably be over 65 if I could possibly avoid it. I mean, so there's occasions when you can't. But it's amazing how much you can do with some reassurance. One of my colleagues in the UK, called Richard Griffiths, plays videos to his patients undergoing fractured neck of femur surgery. Particularly Sound of Music is very popular. And no sedation. Wow. So a spinal anesthetic, no sedation, and videos.
Perfect. Yeah. That's fantastic. Well, Dr. Fleisher, let me ask about, while we're on what we give our patients that can make this worse. So, opioids is a hot topic right now. We know that it can affect our patients, especially those at risk for that. So, is that a conversation piece that you're finding a way that, gives you an in to start talking about this more? Are you looking at it from that angle?
Well, it's interesting. And I don't know if you mean to the patient or the providers.
Yeah. Well, it's the patients. If you continue to give, are they seeing a correlation with opioid? I guess that's where we start. Are they seeing a correlation with opioids in this post-op?
There's a couple different parts of this. Number one is when I ask people, are they actually consenting people from an anesthetic standpoint about the risks of postoperative delirium and cognitive changes? They're not. Maybe 20 to 30%. We've actually seen an uptick, and people aren't sure how to do it. So that's one of the advantages of having AARP and others is they can help us tell the story so that we don't scare the patient. The other thing is, should we be including this as an outcome of our trials? We have not usually included any assessment of delirium or cognitive function after surgery. We need the Deb Culleys of the world, Stacy Diener, who's another member of our team, to actually start including it in trials that are ongoing. And in fact, Mark Newman, who is running the large-scale PCORI grant on hip fractures of regional versus general, includes it in the trial. But I think if this trial had happened 5 years ago, 7 years ago, it wouldn't have been an important outcome. So I think it's interesting as we go to patient-reported outcomes, people care about it.
Well, I think that the way we start working on those assessment tools is, again, starting with the patients. Because, if you can talk to them, talk to your family, how do we know when they're showing signs of issues and things like that we can't necessarily pick up on as a provider if you've only met a person one time or taken care of them?
Well, there's some very simple tests that can be done, again, coming mainly from Deb Culley's group, but many of the other researchers as well, showing, simple things like drawing a clock face and remembering a few words can show that potentially this patient is vulnerable. It's not a diagnosis, but it shows vulnerability that should be very carefully thought about when planning the procedure.
So the interesting question is this idea of informed consent or educating the patient and the provider. And it'll be very interesting when we get together about how we create that material. And even the college, the American College of Surgeons, doesn't have materials yet. And, we're used to talking about medical outcomes that are very clear to us, particularly in the anesthesia sphere and I think in the surgical sphere. And that idea of how much, if we said to a patient, when you go home, you should worry about what happens long term, and maybe be sure that your daughter or son or grandchildren are there for more than 1 or 2 days, or that you have neighbors come in before you leave. That should be part of this shared decision-making informed consent. I recommend people, if they Google Rita Redberg and Kaiser Health News, that there's a story, and Rita is one of the leaders in Choosing Wisely. She's the editor of JAMA Internal Medicine, and she tells the story of her 95-year-old mother and how aggressive people want to be with her, but her mother doesn't want to be that aggressive. So if you included what the potential effect on cognition if somebody is really frail and deteriorating, they may not choose to be as aggressive if one of the outcomes is a lack of independence, or even a worse, even if it's for 3 months, but if you're 95, that's different than if you're 60.
Yeah.
So,
well, Dr. Peden, how are you talking to your patients about this? And actually, have you changed patients' minds because of this information that you're giving them?
I think having very informed conversations, I've certainly had discussions with patients where everything put together, and going back to the surgeon and saying, are there other options, has changed a patient's mind. I think going back to your point about enhanced recovery, where this fits in is if you think about the whole patient journey in enhanced recovery, where you've got the patient and the family very involved in the decision making, informed about the goals and what's going to happen on each day, and also the early mobilization, drinking, eating. All those things are going to be helpful. We don't have evidence yet that they make a difference, but it seems like it's going to be helpful. And we should be thinking about that. We know from the work I've done with elderly emergency patients, when you put them on these very standardized pathways, they do well. So including this in enhanced recovery, I think is very important.
And I think exercise is one of the few things that improves brain health. We don't know if it improves perioperative brain health, but if we're going to do prehabilitation research, this has to be one of the outcomes, because it may actually improve someone's drive, because they may say, well, I won't do it for my heart, but I might do it for my head.
Yeah, definitely. Thank you very much for sitting down with us at the round table and having a great discussion. I think that listeners will love to hear a perspective from you guys. So thank you so much.
Thank you.
TopMedTalk. And don't forget to follow TopMedTalk on LinkedIn, Facebook and Twitter.
Don't forget, of course, you can meet the TopMedTalk team. All you need to do is go to ebpom.org/meetings. There you'll find out all of the meetings that we'll be in attendance at. We've got some great stuff coming up here on Top Med Talk. Make sure you sign up to the email mailing list as well. Absolutely crucial, really, because once you're on board with the email mailing list, we can then contact you and tell you when we're streaming live from the website from one of the many conferences we're in attendance at. And we can also keep you up to date as to how you can meet the Top Med Talk team. So email. Get on there. Get on the email mailing list. TopMedTalk.com. That's TopMedTalk.com.